abdomen has so many organs, we cannot cover everything. So I'll just focus on a few aspects. So mostly nuclear medicine imaging it's about functional imaging, so we can find out the function of the liver, like the hepatocellular function, and how the bile tract is, or how the bile flow is, and how is the reticular endothelial cell activity of the liver. You can find out if there is any accessory spleen after splenectomy. You can find out the motility of the alimentary tract. There is the stomach, gastric emptying, the small bowel, and the large bowel transit. Suppose patients having some, gastroparesis and all that can be identified here. The other is the urogenital. The renal function, GFR, tubular secretion, and the cortical function, detection of vesicular reflex, and testicular viability. Okay. So we have seen this slide before. So we need a radiopharmaceutical. So if you want to study the function of liver, what can be used? So it should be a substance which goes through the liver, right? So most of the drugs are metabolized, many of the drugs are metabolized in liver. One of the important one is lignocaine, which is a local anesthetic, and it is not used as a general anesthetic because it is very easily metabolized by liver. But we take it to our advantage. We label lignocaine with a gamma emitter, and when given, it will be taken up by the liver. So and also it will be eliminated into the bile. In this case, it does not metabolize lignocaine; it is eliminated into the bile. So we can label bile this way. The common terminology for this scan is called HIDA scan, but the radiopharmaceutical that we use commonly now is mebrofenin, technetium-99m labeled mebrofenin. So if we study the uptake, how good the uptake is, how well the liver is taking up the tracer indicates hepatocellular function. How do we do that? You can see that it is taken up by the liver gradually and it's eliminated. So we can draw what is called region of interest around that. Basically these images are nothing but numbers. Number of rays coming from liver. So if we draw a region of interest and find out what happens over time, there is a gradual accumulation of the tracer inside the liver and gradual elimination out of it. So within this ROI there will be a rise in counts or nothing but the number of rays from there, and there is a gradual drop. This is normal. Usually the peak comes around 10 minutes. Suppose if there is a delay, there is an impaired function of the liver, you will find that the curve will be rising and the peak will be coming later than 10 minutes. So with this way we can find out, in fact, in evaluation of donors for hepatectomy for liver transplantation, this evaluation can be done with mebrofenin. The other is, I said, the flow of bile. So we can identify if there is any biliary tract abnormality or if there is any bile leak or collection following a surgery to the biliary tract or some organs adjacent to it, or if there is any duodeноgastric reflex, or if there is how is the function of the gallbladder. All this can be assessed. So one example is biliary atresia, where the biliary tract itself is not well formed congenitally by birth. So the tracer will be taken up by the liver, but there is no biliary tract to eliminate. So it will continue persisting in the liver, and you will not find that the bile is not coming into the bowel. Basically we have labeled bile, so bile should actually come into the bowel if it is normal. If it doesn't come, then there is a possibility of biliary atresia. Suppose if it comes, like you can see here, then you rule out biliary atresia. There could be other causes of why the bile is not coming delayed, or why the bilirubin is elevated. I said another probability is like biliary tract abnormality, a choledochal cyst. This is a case of a rupture of choledochal cyst into the peritoneum. You see, instead of, there is a collection here because of the choledochal cyst, it is a dilatation of the biliary tract, and there is rupture of the choledochal cyst into the peritoneum. What you are seeing is, instead of bowels, you are seeing activity in the peritoneum. So that, for this also you can use, usually bile leak occurs after a surgery, after biliary surgery. Another is like evaluation of ejection fraction of gallbladder. So normally bile is needed for fat digestion. So when we take a fatty meal, gallbladder contracts. The stored bile comes out into the intestine. It is similar to the ejection fraction we calculated for heart. So we have to find out the peak accumulation in the gallbladder, and after meal find out how much has gone out of the total activity will give the ejection fraction. So by making a region of interest around the gallbladder before and after a fatty meal. There is reticular endothelial cell activity. Kupffer cells are a kind of reticular endothelial cells present in liver, which can be used, and also spleen also has reticular endothelial cells. So if patients with ITP or other causes of platelet or RBC depletion will undergo splenectomy to save the cells. But despite the surgery, they may present with anemia or thrombocytopenia. In such cases, there could be a small, congenitally very small spleen, which is not removed at the time of surgery, That could be the cause of it. So we can detect that very well with either the sulfur colloid, it's a colloid particle taken up by the endothelial system, or by denatured RBC also can be done. The other I said is the motility of the alimentary tract, the stomach. How quickly or how delayed is the movement of food out of the stomach can be studied by labeling food. So food is converted into a radioactive substance, basically mixed radioactive substance with food, and the patient is asked to eat or drink. It could be a solid or a liquid. So it goes along with the food or the water. So what happens over time, we can find out how it is going out of the stomach, whether it is delayed or not. Nowadays we don't do a continuous study, we take static images or called pictures, static pictures. So if more than 10% of the given radiopharmaceutical is retained in the stomach at 4 hours, it is considered abnormal. Another interesting indication is like the Meckel's diverticulum. Okay. Presence of Meckel's diverticulum, it can cause intestinal obstruction, can cause bleeding. Bleeding occurs when there is an ectopic gastric mucosa and cause erosion of the mucosa, adjacent mucosa. So what happens, this ectopic gastric mucosa or the gastric mucosa per se takes pertechnetate, this technician in pertechnetate, which when given goes to stomach mucosa as well as to the ectopic gastric mucosa. In this way, we can detect if there is a Meckel's diverticulum. Coming to the renal part, so we can study the function of the kidney by assessing the glomerular filtration with the help of DTPA or tubular secretion with the help of EC or MAC3. So this is an example, like EC or DTPA study will look more or less similar. You can see this kidney is, these are the posterior views of left kidney, right kidney. Right kidney is enlarged and it's hydronephrotic, and over time it's keeping on accumulating the traces. That means over time there is a rise in the counts in the right kidney, whereas the left kidney is showing drop. That means over time there is no retention here. So that means it is non-obstructed, and this means it could be obstructed. And also by drawing region of interest, I said this again, numbers only, number of rays, we can find out how many counts are there in each of the region of interest and can find out what is the individual contribution of each of the kidneys. The other one is cortical function. We use some traces which called BMSA, which gets filtered through GFR, but it's retained in the proximal convoluted tubule, which is predominantly found in the cortex. So it is a cortical scan. This is a normal kidneys, pair of kidneys. Here also you can draw region of interest and calculate the differential function. These are kidneys which have multiple scars because of infection, previous pyelonephritis. This is an active pyelonephritis, and this is a renal anomaly, that's a horseshoe kidney. Reflex also we can instill tracer into the bladder, and the child or the patient can be asked to void, and if there is backward flow of urine into the ureter into the kidney, that can be detected easily. My surgery professor used to say that like examination of the abdomen doesn't end without examination of the genitalia, so I'll end with this. So we can use tracers for evaluation of the scrotum when there is a testicular torsion. Blood flow to the testis can be compromised, and that can be detected by using as finding of the vascularity of the testis. By using same pertechnate can be used, sodium pertechnate can be used. Yes, thank you.